My screen visible?
Yes, sir. Visible, sir.
Okay. So the anesthetic implications in Hipec intraperitoneal chemotherapy surgery. It is hyperthermic intraperitoneal chemotherapy. That is the acronym for this. So primary peritoneal neoplasm and metastasis to peritoneum. It can be from gynecological or gastrointestinal cancer. Earlier they had a very poor prognosis. So once you know that it is spread to all these places, they used to say stage them as a last stage and dump them as untreatable. Now, surgical removal of this visible tumor from peritoneal mesothelium combined with loco-regional heated chemotherapy drugs improve quality of life and survival of the patients. Now, this now has become a well-established treatment for all these types of cancers which you mentioned, like colorectal, ovarian, and gastric cancers. Now, of course, you have mentioned how this technique works. But in exam, if you don't have time, you don't have to waste your time in describing how it is acting and all that, because the main thing, you have to save your time and write more about the anesthetic implications rather than describing the methodology of how
Yes, sir.
this technique works in clearing the tumor cells and other things. So a team approach for care of these patients improves patient outcome. This is the first and foremost. It requires a lot of cooperation from other team members. A unique aspect is it has got severe hemodynamic fluctuations. It can cause hypothermia during cytoreductive phase of the surgery. And once you go to the stage of installation of the heated chemotherapeutic agent, it produces induced hyperthermia. You are artificially creating a hyperthermic state and potential for the toxicity of the chemotherapeutic agents that you are using for that purpose. So these 4 points have to be highlighted: hemodynamic fluctuations, hypothermia due to the extensive reduction surgery where the abdomen is open, patient is exposed, and there is an ambient temperature which also causes a reduction. So after that, suddenly once you start instilling the chemotherapeutic agent, it becomes hyperthermic. So what are the preoperative concerns of these patients? You must, of course, control all the morbidities, and you must select the patients, as you rightly said. Patient selection is very, very important. They should have a strong cardiovascular function. If they are already compromised cardiovascular function patients, they will not do well because of the hemodynamic fluctuations that are likely to happen. So, but if they are under good control with comorbidities like diabetes, hypertension, then you can take them up for this surgery. And the additional risk of previous radiotherapy and chemotherapy, their effects also have to be taken into consideration. And patients and caregivers, they should be informed of the regarding the therapy as well as the expected outcome, cost involved, risk involved, quality of life, and need for systemic chemotherapy. All these things should be very clearly explained and documented. And rehabilitation is an important part of preparation for good surgical outcome, and it should include patients' preoperative nutritional status and albumin level, which point you correctly said. So these patients usually, they are not able to eat, they will be in a poor nutritional state with sarcopenia, marasmus, and low albumin levels. So all that also should be prepared properly so that they can withstand this stress of this surgery. And they may have ascites and pleural effusion, which may lead to basal atelectasis, which disposes to the increased risk of post-op respiratory complication. So if you need to drain all these collections, it is better to do that so that respiratory function will not be compromised in the post-anesthesia state. And you can do intensive spirometry to improve their lung function and reduce the incidence of pulmonary complications. And they have an increased risk of venous thromboembolism. So you must take a decision as to what type of thromboprophylaxis you must do. Whether you have to start anticoagulant like heparin or low molecular weight heparin prior to surgery or in the immediate post-surgery period, or whether any mechanical devices like compression stocking should be taken. This is another important point which you have to consider in the pre-anesthetic phase itself. And there will be large amounts of fluid shift during the cytoreductive phase, and hyperthermia during hyper leads to peripheral vasodilatation, a reduction in peripheral vascular resistance and mean arterial pressure. But this will lead to a hyperdynamic circulation with increase in heart rate, CVP and cardiac index to maintain tissue perfusion. Now coming to the intraoperative concerns, abdominal distension due to ascites decreases functional residual capacity, as I said earlier. That has to be corrected prior to surgery, or if it is a mild one, you have to take into consideration to prevent the effects of lowering the FRC. And this may predispose to desaturation. So you have to plan for a rapid sequence induction with adequate pre-oxygenation. And patients undergoing Hipec are prone to coagulation abnormalities, so that also have to be taken care of. And the neutral deficiency and hypoalbuminemia due to ascitic fluid drainage all to be corrected. And the surgery is a quite long procedure, may take 8 to 10 hours. So long duration, female gender, old age and malignancy, these are all the causes for thrombosis. So if these type of patients, you have a female patient who is elderly and the malignancy has spread quite far, then you have to think of thromboprophylaxis prior to surgery itself. And large laparotomy incisions require good post-operative analgesia. So for that only you have to install epidural even before starting your GA. So epidural provides good analgesia, but is associated with risk of hemodynamic disturbance due to extensive surgery. So, and if there is a coagulation abnormality, there is always a chance of spinal hematoma. So the advantages have to be weighed against the possibilities of these complications. And primary opioid-based analgesia should be used with caution, because these patients may be already taking some morphine for the pain of the cancer. And so you have to use the morphine in a very titrated dose and think of any possibility of respiratory depression due to morphine and be ready to support the ventilation. And patients who receive morphine for cancer pain relief may require increased dose because they would have developed a tolerance. This is another point you have to keep in mind. Paravertebral blocks, which has a single shot technique or a continuous technique, subcostal tab block, also are good alternatives without causing any hemodynamic disturbance compared to epidural. Coming to the invasive monitoring, functional hemodynamic monitoring in the form of cardiac output, stroke volume variation, and delta stroke volume, that is variation, stroke volume variation occurring per beat to beat, particularly when the PCA is recommended more than 15. You know what is PCA here? What is the expansion for PCA? Sanjuta?
No, sir.
It is not percutaneous cardiac intervention as you get it in ACS. Anybody who can give the expansion for this PCI?
Cardiac index, sir.
Huh?
Cardiac index.
Cardiac index. What then? What is that P stand for? It is nothing to do with the cardiac thing. It is a acronym for cancer state. That is the clue I can give you. It is called peritoneal cancer index. Okay. That is calculated by dividing the abdominal cavity into 13 quadrants. Depending upon the number of seedlings or metastases that happen in the various quadrants of the abdomen, they have divided the abdomen into 13 quadrants, and the maximum seedlings found is given points from 1 to 3. So very small number of seedlings, it starts with 1, and a large number of seedlings, they can give a point up to 3. So 13 into 3, you can get a maximum score of 39. And if it is more than 18, it requires a extensive surgery and extensive therapy. So that is what is called, it's called peritoneal cancer index. Of more than 15, you are required to do for a goal-directed fluid therapy to maintain normovolemia and prevent acute renal failure. And the measurement of what is EVLW?
Extravascular lung water.
Extravascular lung water. Very good. It's using the volume view of Vigilio, measuring lung water is particularly helpful for predicting the fluid overload and overall morbidity during and after Hipec. An arterial line is a must to monitor beat-to-beat blood pressure to guide inotropes and ABG sampling. And central venous pressure and pulmonary artery catheter should be individualized. It is not the compulsory routine for every case, but you should think of it depending upon the extent of surgery. This is where you have to discuss with the surgeon how far he is going to resect and what is the possibility of the duration and the treatment. And their usefulness in predicting fluid responsiveness is limited. And you must measure the patient's height, weight, and body surface area, which should be documented to calculate the doses of not only the anesthesia drugs, but also chemotherapeutic agents and their dose modifications, depending upon the renal, hepatic, and cardiac dysfunction that is already present. And the specific side effects of chemotherapy drugs, drug-specific potential toxicities also should be known to the anesthetist so that he can anticipate those complications and manage them. Now, this is the Edwards Life Science Vigilio monitor, which some of you would have had a chance to see this. This is another version of flow track monitor. So, flow track Vigilio system using data from both arterial line and central venous line to calculate the various hemodynamic parameters. And on the left side, you find some short forms as well as in the right side. So, the expansion for that SVV is stroke volume variation, SV is stroke volume, SVA is the stroke volume index, and these two things, this is global ejection fraction and global end diastolic volume. So, it measures the entire functional status of the heart and also extravascular lung volume, the lung water, so that it can anticipate the presence of fluid overload and edema earlier before it can happen. So this much of intensive invasive monitoring is very, very important. This has to be mentioned in your answer to make it a nice presentation. Now, these are the common side effects and adverse effects of chemotherapeutic agents, and these are the common agents that are used: cisplatin, oxaliplatin, doxorubicin, mitomycin, and irinotecan. All these things have these problems. In addition to this, cisplatin has got, as she rightly said, prolongation of QT interval, which can lead to get converted to ventricular tachycardia. And body temperature is monitored by two probes. One temperature probe is placed in the esophagus for core temperature monitoring. And the temperature of the abdominal cavity is measured by thermistors present in the inlet and outlet drains of the Hipec machine. Okay. And apart from this, there are at least 3-4 probes placed in the abdominal cavity during installation of this heated chemotherapeutic agent. That will be kept 2 in subdiaphragmatic area and 2 on both sides of pelvis to maintain a temperature of more than 41 degree, at least in all these areas uniformly. And during debulking phase, patients are prone to hypothermia due to extensive surgical resection, exposure, and excessive fluid loss, and prolonged duration of surgery. And intraoperative core hypothermia should be prevented to prevent coagulation and metabolic derangements, which all of you know, all the side effects of hypothermia. Next important thing is fluid management. During cytoreduction of tumor, there will be losses up to as high as 8 to 12 ml per kg and may be associated with blood loss also. Not only fluid, it may be blood loss also, depending upon the extent of resection. So initially you can manage that with crystalloids and colloids to ensure adequate perforation, and watch out for the urine output. See whether the urine output is satisfactory to maintain renal perfusion to prevent acute kidney injury. And the patient's higher disease load, high preoperative cancer index or the peritoneal cancer index with extensive resections may require blood transfusions. And if the available salvage of lost blood, this is one new technique they are using here to normally blood shed from the operative field in a cancer patient. Earlier advice is not to use it as a cell salvage procedure because you can retransfuse the cancer cells. But now facilities are available to irradiate the red blood, the blood that is being shed in the operative field to eliminate the cancer cells, and you can retransfuse that large volumes of the operative field blood itself. But if it is considered risky, then you have to go for bank blood only, and that may be associated with the regular complications of blood transfusion. So this is one new point that you have to remember, that you can irradiate and reuse the blood that is collected from the operative field. And goal-directed fluid therapy instead of liberal fluid therapy provides a better perioperative recovery as well as less complications. Now, intraoperative measurement of urine output is a reliable, non-invasive surrogate marker of renal perfusion. So, what should be the aim to maintain urine output? 0.5 ml per kg during cytoreductive phase. Then once that is completed and patient goes to Hipec stage, you should have a little diuretic phase, that is 2 to 4 ml per kg per hour. And then post surgery or post Hipec phase, it should be 1 to 2 ml per kg. So it is not a constant amount of urine output. Cytoreduction, you can have a little lesser. During Hipec, you must have a diuretic phase with a higher volume of urine. And post Hipec, you can have a reduced 1 to 2 ml per kg. And diuretic should be used only after ensuring adequate volume status and optimal renal perfusion with a good blood pressure or a mean arterial pressure. And intraoperative electrolyte disturbances or can hyperglycemia due to absorption of dextrose containing peritoneal instillate carrying solution. That is, the Hipec solution is sometimes mixed in dextrose and that can get absorbed. And cisplatin can cause hypomagnesemia, which may lead to cardiac arrhythmias. Oxaliplatin causes lactic acidosis, hyperglycemia, and hyponatremia. And electrolyte disturbances like calcium, potassium, magnesium should also be looked for and corrected if required. Now coming to the post-operative and critical care management of hemodynamic stability. Otherwise, all the intraoperative maintenance is your regular way of induction with propofol, intubation, and then maintenance with a neuromuscular blocking agent with controlled ventilation. That is the routine maintenance, so I have not mentioned about that. And post-operative critical care management, you have to manage the hemodynamic stability, you have to watch for the coagulation profile, and you have to watch for the electrolyte imbalance and fluid shift during the immediate post-operative period. Now coming to the analgesia, you must use the multimodal analgesia with a combination of local anesthetic and opioid. It can be thoracic epidural or the other blocks such which I mentioned earlier. You have to use NSAIDs with care if there is any period of hypotension where there is likely to be a mild acute kidney injury. And stress ulcer prophylaxis is very important because these patients may be mechanically ventilated in the post-operative period, and they may be in requirement of vasopressors, non-steroidal and anti-inflammatory drugs. And thromboprophylaxis, of course, we have been talking about it again and again. So you have to think of heparin or low molecular weight heparin. And early enteral feeding is always better, and you have to think of that as soon as possible. And for any reasons like any surgical complications like the ileus or anastomotic leak where you cannot give enteral feeding, you must start parenteral nutrition also at the early stages where patient is unable to take orally. And respiratory parameters should be should improve after cytoreductive surgery and ascitic drainage because the abdominal distension is reduced. Many patients may require a few hours of post-operative ventilation due to hemodynamic instability that can happen, or because of diaphragmatic injury or multiple comorbidities preventing safe extubation. And there are these patients are immunocompromised, so they may have infective complications. So you must think of escalating to higher antibiotics apart from the routine antibiotic protocol that is followed in the hospital. Now, in patients undergoing this, of course, this is just for the information's sake. The challenge to fluid shift, temperature changes, increase in intra-abdominal pressure, and increased metabolic rate, all these things happen. So it is utmost important to be vigilant with fluid management and hemodynamic monitoring perioperatively. And use of regional anesthesia like epidural will be a very good method to alleviate the intraoperative stress. And knowledge of both chemotherapeutic, this is something like a concise form of what you have to write. So I just thought it's all a repetition of what we have seen so far. Now this picture gives you an idea about open technique of Hipec surgery, where abdomen is opened and you can see these are the tubes which deliver the chemotherapeutic agent at a higher temperature, and you have one inlet and one outlet there. So fluid will be constantly circulating here, and the whole abdomen is heated up to this. This is the open technique. And this is called the closed technique of Hipec surgery, where after installation of the Hipec, the chemotherapeutic agent at a higher temperature, the abdomen is closed, and these tubes, these three tubes will be delivering the Hipec solution, that is a chemotherapeutic solution, and these tubes will be draining it, so that there is no evaporative loss and there will be a constant temperature maintained. And this is much more a preferred technique rather than this open technique. And what are the safety in theatre during Hipec surgery? This also we have to include in our answer. The theatre personnel exposure to chemo agents can arise from different routes. It can be by air contamination because these agents will be getting effervescent and coming to the OT atmosphere. So it can cause pulmonary absorption, or it can come into contact with the skin, contact contamination, or when the manipulation of percussates, the personnel should be very careful that they should not have any direct contact with these chemotherapeutic agents. And the bodily fluids which are left out in the abdominal cavity or other areas, they can contain chemotherapy agent up to 48 hours. So any drainage that is coming, again, there should be the personnel should be quite careful. And closed technique surgery provides the highest level of protection for the surgeons and other assistants who are operating on the patient. And the education and training of personnel who are preparing and using chemotherapy in the operating theatre is important to minimize the risk of the personnel getting affected. And periodically there should be medical surveillance of personnel to see whether they have been affected with this by doing routine blood counts and looking for any adverse effects in those persons is important. and appropriate personal protection equipment, just like what you have done during COVID times. It's very, very important for to be used by all participating personnel at all times. They cannot be quite relaxed or negligent in this aspect, and they should use filtering masks and change those masks every 2 hours. That is during the Hipec procedure. As she mentioned, it can be from anywhere between 30 minutes to 2 hours. So if it is going to take more than that, it is better that the mask is changed every 2 hours. Double gloving and wearing gloves, with changing them every 30 minutes is also advised. And goggles should be worn in order to protect eyes from the splashes of these chemical solutions. And adequate ventilation and a smoke evacuator are essential for the control of air contamination in the OT. And the air conditioned filters should be of high efficiency. Particulate air HEPA filters should be there, and doors should be closed airtight during the surgery, and unnecessary movements in and out of OT should be avoided. And notices should be placed outside the doors to alert people to the use of chemotherapeutic substances that is being going on inside the theater. So these are all the important safety precautions that you have to follow during surgery. So I think if all these points are included, your answer will be complete and